Good afternoon and welcome to the first virtual meeting of the Kansas Rural Health Innovation Alliance. As a part of the application development process, we welcome you today. We're looking forward to hearing your insights and feedback. All right, let's get right to it. I am Sheena Schmidt, and I am the strategy team leader and a senior analyst at KHI for the Access to Care strategy area, which includes Medicaid policy, behavioral health, workforce issues, and rural health issues, among other. We are happy to be able to support today's facilitation. I'll go over the agenda. Um, we'll have welcome and opening remarks from KDHE and KDADS. Then we will transition to going over a meeting overview objectives and giving a little bit of context about the process. Then we'll hear about the Rural Health Transformation Program overview and the application framework. Following that, we will introduce and discuss together a draft mission and vision for the Alliance in order to inform the application process. We will then hear from Dr. Bob Mosier on emerging themes that have resulted from stakeholder meetings and engagement thus far, and that will inform our breakout room discussions that we will have, which will be an opportunity for participants to provide feedback on some key questions to help the application team develop the application. We will then close by sharing out what we heard today in the breakout discussions and going over next steps in the process. Now I will turn it over to Matt Lara and Lee Keck for the Chiefs of Staff for the Kansas Department of Health and Environment and the Kansas Department for Aging and Disability Services to provide some comments and context for today's meeting. Thank you both.
Thanks, Sheena. On behalf of Secretary Stanek with KDHE and Secretary Howard with KDADS, I want to say thank you all for being here. Both secretaries are away at a policy meeting today, so Lee Keck, who is Secretary Howard's Chief of Staff, and I are happy to be here on their behalf. Like I said, thank you for joining us and recognizing the importance of your participation in shaping Kansas Rural Health Transformation application. This meeting kicks off our multi-phase stakeholder engagement process to co-design initiatives that will inform the foundation of the statewide application, which is due in just a few weeks. The vision for the Rural Health Transformation Program really is to transform rural health in Kansas through sustainable and community-driven change. And we'll do this with a focus on improving access, sustainability, and innovation in rural healthcare delivery. The goal for today is to collect meaningful input to help shape Kansas' application to CMS, and that is why you all are here today. We have a rural health transformation application team that is being led by KDHE in partnership with KDADS, as well as the University of Kansas Health System Care Collaborative. We have several members of the team on the call today. We have Lee Keck, as I mentioned earlier, as well as I believe Ashley Goss, who's the Deputy Secretary for Public Health here at KDHE. For the University of Kansas Health System Care Collaborative, we're working with Dr. Bob Mosier, as well as Jody Schmidt and Marty Ross. This team is responsible for synthesizing all the stakeholder input that we've received, coordinating agency collaboration, as well as drafting the CMS application over the next few weeks. So I want to thank them, the team, for their ongoing work and commitment to transparency and inclusion throughout this process. Supported by the Kansas Rural Health Innovation Alliance, which is all of you, the governor appointed this advisory body to represent rural health leaders, providers, and community partners. This collaboration ensures the application reflects the full spectrum of perspectives across rural health in Kansas. We're doing this through a stakeholder-informed and data-driven initiatives that advance access, sustainability, and innovation in rural Kansas. As I said, this application timeline is moving very quick. I think we have about 3 weeks until it is due. We're doing it through the multi-phase engagement process. And so this is our first meeting of this group, but we've actually, KU has started stakeholder input and interviews already, and those will continue through next week on October 15th. We have our virtual meeting today as well as one next Thursday to review and refine the initiative concepts. And then we'll have the in-person convening on October 20th to finalize the draft initiatives and ensure alignment across all the entities. October 24th through November 3rd will be a busy time for the application development team as well as our interagency task force as we're drafting and reviewing the application. And then it is finally due to CMS on November 5th. So it's moving very fast, and we understand how everybody's time is important, so we appreciate you taking the time to do this. So thank you for your partnership, and we can use this process as an opportunity on how together we can transform rural health in Kansas. And so before I turn it back over to Sheena, I want to see if if you have any comments you want to make.
We would just echo what Matt had said. Thank you so much for joining us today, and we look forward to working with you in this process.
Perfect. Thank you. And I'll turn it back over to Sheena now.
I'll be helping facilitate us through the agenda today. So here are today's objectives. We're here to introduce the Kansas Rural Health Transformation Program and provide the vision and context for the statewide application process, clarify how stakeholder input will shape the final application, share emerging themes and topics from early input and connect them to program goals, and gather stakeholder feedback to refine ideas and identify opportunities or gaps. But before we dive into today's work, we recognize that everyone is coming to this conversation with different perspectives and perhaps some questions or uncertainties. So we'd like to start by hearing from you on what you are thinking about the process, and your insights will help us ensure the team develops the strongest possible application for Kansas as we work together to transform rural health. So, what I'd like us all to do is I'm going to take us through a compass points exercise. So, please feel free to come off mute. We'll go through each question one at a time. You can come off mute and share your thoughts and also enter them in the chat. And we will just have a free flowing discussion to get us started thinking about how we might transform rural health together in Kansas. So first question is, what excites you about the idea of transforming rural health in Kansas? And once again, I invite any of you that would like to provide comments to come off mute, or please go ahead and share them in the chat.
Gina, this is Chad Austin with Kansas Hospital Association. I'll kick it off and then maybe others can jump in. But obviously, from a Kansas perspective, I think this is a great opportunity. It's a generational opportunity for us to kind of shape the state of Kansas as it relates to rural health care. Over the course of my career, over the last 26 years, I think Kansas has been a strong leader in rural health care delivery, whether we're talking about the critical access hospital program, or we're looking at the rural emergency hospital program, or many of the hospital networks that we have across the state from my vantage point. I also think it's really an exciting opportunity to kind of take a step back and look, as Ed O'Malley would say, from the balcony in terms of what can we do to really better the health of Kansans. And from kind of the mission statement and the vision statement that we have that we try to follow, which is optimal health for Kansans. And so recognizing that we're all part of the ecosystem, working together to really strengthen the delivery that we have within each of our communities across Kansas, kind of really exciting from my vantage point. And I think there's a lot of opportunities and looking to develop a strong application so we can be, again, the leader in rural healthcare delivery for our country.
Thank you so much, Chad. What a way to kick it off. Would any others like to provide perspectives or comments? I see some coming in the chat, but I'll let others come off mute and share verbally as well.
Sheena, this is Ed from the Kansas Health Foundation. I'll hop in. I know there's a lot of moving parts of this. I'm excited for the next part of the compass too, because I think there are some things we all need to watch out for. But it is kind of an amazing opportunity. It's if we can work together and figure out how to do this together, this is an incredible opportunity for the state of Kansas and for the people of Kansas. And so I think I'm most excited about um, the opportunity for this team that's available on this call today to find a way to coalesce and be as a team. And I know that'll be hard to do in a short time frame. I know we didn't control the time frame, and the secretaries are doing a great job trying to move this forward. But what excites me is about can this group become a team and really deliver for the state of Kansas? I think we can.
Thank you, Ed. A lot of synergies in the first two comments. I'll move to the chat. So some things I'm seeing is, Jennifer Finley says this project allows us to make sure our health delivery system and our communities are healthy now and in the future. Um, Linda Mowbray, so much potential exists in the rural parts of the state. So excited to see the spotlight on this population. Comment from Greg Hennon, increased accessibility to a full array of healthcare services, integrating behavioral health in multiple settings. I see Tara, you've raised your hand. Please come off mute and share.
Sorry, Sheena, I didn't mean to raise my hand. I was trying to type in the chat, but this is Tara Remington Brown with the Kansas Academy of Family Physicians. And what I was going to say is I think this is such an exceptional opportunity to increase access to preventative health care in our rural communities, which in many instances, have care deserts or access to care is a difficulty. So like Ed and Chad, I'm just so excited about the opportunity to collaborate with all of you. We all work really well together, it seems like already in Kansas, and this is just such a great opportunity to continue that good work for all of Kansans, but particularly those in our rural communities.
Thank you so much. Thanks for being willing to share verbally. We appreciate it. All right, I see some other comments in the chat. Kiana, leverage the plan as a catalyst and platform for public, private, and philanthropic partnership and investment. So some innovation. Craig, increasing access to care, including mental health crisis care to lower the impact on emergency departments. From Kylie, how the rural healthcare delivery system can impact other aspects of our state, from workforce to education and beyond. So bringing that health and all policies perspective into the conversation. Aaron, increased access to care and coordination across the care continuum. From Brandon, the opportunity to scale important work beyond one network or one delivery system. So that theme of working together. And from Bob Kraft, what excites him is the increased coordination and opportunity to talk about the dental care crisis looming in rural Kansas. And from Carrie, I'm hearing coordination and integration resonating in the chat. Yes, definitely. And people are thinking about how to work together and leverage the strengths of different parts in the system to maximize impact for Kansas. All right, so lots of things to be excited about. I'll now transition us to looking to the West. What concerns or what considerations will you watch for in the work to transform rural health in Kansas? So I invite you to continue sharing what you're excited about, but also transitioning to think about concerns or worries you might have. So please share in the chat or feel free to come off mute and share. Sustainability. That's something definitely we will explore throughout this process. What you're watching from Aaron, healthcare will change in the future with or without this project. We need to be careful not to be perceived as picking winners or losers in this project. So then, to work as a team. From Doug, we need improved telehealth access in Western Kansas. Another comment about sustainability and truly serving rural areas where services aren't available. We need to keep our eye on the big picture and not just focused on our interest area. Again, that theme of working as a team and having the opportunity to approach it as a team. Ed?
Yeah, thanks, Sheena. By the way, I know I've been in your shoes a lot, and I know it's nice to have people, use their voice as well as the chat. So I'll speak up again. I want to just build off that last comment you read. I think what I'm going to be watching for is I know there are a lot of us on this call who have a very specific role or sector or piece of healthcare, rural healthcare that we focus on. And then there are some of us, maybe like the foundations who are involved, who are a little more generalist. And I think what I'm going to be watching for is like the degree to which other people start advocating for and protecting the interests of other parts of the system besides just their own. I think, the key question I think on our minds is, are groups here to get as much as possible for their piece, or are we here to create something together in coordination that will benefit everybody? So like that's something that I know I'll be watching for, just like how do we all support each other? How do we advance the interests of other groups, not just the group we happen to represent in this effort?
Thank you, Ed. And I'll move to Chad and then Beth.
Sure, thanks. Just a couple things that I'm kind of thinking about as I'm looking towards the conversation. One of which is just the transparency, making sure that everyone feels comfortable with the process. I would say, we're all in the similar situation. What I mean by that, all 50 states. And when there's a lack of transparency, that leads to a lot of speculation, and that speculation leads to paranoia and typically to negative perspectives or views. And so how do we kind of make sure we're all communicating openly with each other and with our respective members? And then also just knowing that, yes, this is an opportunity for transformation, but recognizing that in some situations, providers or communities are looking just for stability. And it's hard to really think about, for those communities to think about transformation when they're really focused on the next day, the next week, the next month, and looking at that. And then the other item that I would say from my vantage point is I really do appreciate that this is more of a provider-driven approach, with providers and community members and foundations that are really providing some guardrails into conversations. And so I think if we can keep it in that lane, I think there's a lot more beneficial activities and possibilities for us to have a stronger application.
Thank you, Chad. Beth?
Yeah, hi, I'm Dr. Beth Aller, and I'm the president-elect of the Kansas Academy of Family Physicians. I work at a rural critical access hospital, and we are a rural health clinic. So I feel strongly the importance of that, but I want to make sure that we continue to focus on the fact that keeping our hospitals vibrant in there is so important. But we want to focus on prevention too. We want to make sure that our patients have a medical home, and that we are doing the best we can to keep them out of the hospital. And one of the biggest areas of health that we see that is difficult to access in most of our rural communities is mental health. So I'm very interested in seeing that expanded for whole person healthcare, but also addressing things like food deserts and how difficult it is to get access to fresh and sustainable foods in a lot of rural areas, or at least that's financially accessible. So I want to, make sure we keep that in mind more than just, it's like someone else had said, that urgent healthcare need, and yes, keeping our hospitals there, but focusing on prevention, whole person health, and mental health care.
Thank you so much. I'm not seeing other hands raised, but feel free to come off mute and continue sharing. But I'll turn to the chat for a couple of comments that have been shared to lift those up. So a comment, will we look back in 10 years and see $1 billion spent but no real transformation? Will we look back in 10 years and see the $1 billion as a distraction from real reform? So a couple of questions. Kiana's watching for strong inclusion of our safety net system, like FQHC, CMHCs, CBHOs. Robert Stiles, that the approach focuses on a whole communities and systems and their health and success. A question from Jason, does rural America want to transform? From Brenda, does shovel-ready projects as required by the application equate to investing in sustainable statewide improvements? So a little bit of push and pull there. The need to balance the focus of prevention with addressing immediate health needs, from Denise. Concern about the time available to really flesh out a transformational sustainable model. watching for continued engagement, if pet projects are not selected, and encouraging each other to stay engaged, and focusing on prevention as the catalyst for transformation. So I'm seeing a lot of themes around focusing on prevention, ensuring that whatever is selected for inclusion in the plan is sustainable, and focusing on holistic approach, keeping others engaged in the process, even if they're not seeing exactly what they want to show up in the application showing up in the end. All right, so we have a few more minutes. I'm going to transition us to the next question. That doesn't mean you can't still share some things in the chat, or keep thinking about these questions and share them after the meeting. So looking north, what else do you need to know or find out about the approach for transforming rural health in Kansas? So as we're thinking about this process in the next 3 weeks and beyond, what would be helpful to know?
I guess from my perspective, what role can we play from being a part of this group, working with our respective membership and stakeholders and colleagues? How can we best bring value to this group to develop the best program that we can in application for Kansas? I think all the states are going to be in a similar position that they're scrambling to put together their application and really trying to figure out what can we do to bring to the table to make our application stronger than, the other states that are also applying.
Thanks, Chad. I appreciate that perspective. All right. See some things coming in the chat. Carrie?
Yeah, probably just going to echo what Chad said. I think we need to know what is the most effective way for this group, all of us individually, and then collectively as the group that's convened. How can we help do what Chad just said? Make sure that we can have the best application for Kansas that makes that not only is transformative, but also maximizes the opportunity for resources to make that happen. So how can we all be most helpful? We really need to know that.
Thank you. All right, some comments in the chat. A need from Kelly: it is important to ensure that the needs of children are included throughout the process. Return on investment for children, investment in children is high, and prevention of chronic disease begins with healthy pregnancies and healthy children. From Brenda: how or will the final application be circulated and vetted by this group prior to submission so that we are on the same page to the extent possible when communicating with the public? Brandon shared: are policymakers interested in making needed changes to make sustainability possible? What are the expectations of this group? So just some questions about clarifying the role of KRHIA in the process and stakeholders. The evidence-based list of factors contributing to poor rural health. So some need for some information and data to inform the plan. Sustainability of intervention and the ability of an intervention to create a momentum of its own. From David Jordan: how can this group participate in a meaningful way to help leverage expertise to ensure with the strongest applications? So similar to Carrie and Chad's comments. Does the governor and state have some direction or priorities to focus on? How can we ensure a comprehensive input across the healthcare spectrum in the limited times that we have to meet? And will there be a provider, practitioner, community input opportunity? All right. So we will be collecting those questions, and if we don't get to answering all of them today, the goal of this exercise was to gather them so that we can understand better what the needs of the group are, and then the team can respond accordingly. So we'll share them following the meeting and including the notes. Again, I know that it's a short timeline, but we thank you for your participation and thank you for your honesty and transparency and participation in this process and going through this exercise. It really will help strengthen the team's ability to respond and to provide the best application for Kansas. Before we transition to the next item on the agenda, are there any other thoughts or comments related to this discussion that anyone wants to highlight? Okay. All right. Well, appreciate all of everything that what everyone shared about what's exciting them, what they might be concerned about, and what they need to know. As our process continues, we're going to look to the South today and beyond in our next meetings on what suggestions you might have for transforming rural health in Kansas. And so that's our task for today and in the next 2 meetings. And we look forward to engaging you in this process. All right. I'm now going to turn it over to Marty Ross with the application development team to share about navigating the notice of funding opportunity, some requirements and information about that to guide our further discussion. Thanks, Marty.
Thanks, Sheena. And thank all of you for answering the governor's call, willing to participate in the alliance and share your vision of where we can go. I'm really encouraged that the number of times the word collaboration was repeated in this preliminary discussion, because it is going to take a high degree of collaboration to get this done. Not that I'm counting the days, but I'm counting the days. It's 27 days till this application has to be submitted. And I agree 100%. If I had been in charge, we would have had a 6-month to a year planning period in which the states would be able to convene stakeholders and be able to outreach to communities to really develop a full-throated plan for transforming rural health. But what we have now is 27 days, given the confines of the legislation that created the Rural Health Transformation Fund. What we also have is a notice of funding opportunity that confines what the plan needs to look like. And we certainly have to navigate those requirements because the name of the game here is getting the money to the state to implement the plan that's developed. So let's walk through some of those key components of the notice of funding opportunity. I will try not to repeat everything we talked about in the webinar on the 29th, but trust me, I've read NOFO about 10 times and I keep picking up new stuff every time I work through it. So maybe it's okay to repeat this a couple of times. But we have $10 billion, the federal government has appropriated $10 billion a year for 5 years, beginning in 2026. Note, this program is impacted in no way by the government shutdown, except for the fact that CMS is not able to post on its website updated FAQs. But they have made clear that the application will still be due on November 5th. They still fully intend to make awards by December 31st. By statute, the $10 billion each year is divided into 2 funding types. The first is the baseline funding. The second is the workload funding. The baseline funding is, by statute again, divided equally among those states that submit an approved application. And we're going to talk about the elements that have to be in that application for it to be approved. So that's table stakes to get your first $100 million a year, assuming, again, all 50 states have an approved plan. The workload funding is the competitive aspect of this opportunity. And the amount a state receives in the workload funding is tied to 2 things: certain objective criteria tied to the rurality, I love that word, rurality of the state, and then the content and quality of the state's application. So objective and subjective elements to that. We are required to build a budget based on $200 million annual award. The budget that's presented in the application will go through a negotiation process before the end of the year with CMS. Well, they'll want to move money around, take certain elements of the program and the like before they make that final decision on how much that they're going to approve. The critical here to remember is that all of the funds that the state receive have to be used on the initiatives that are detailed in the state's Rural Health Transformation Plan. So this is not a slush fund by any stretch of the imagination, that the state will be accountable to CMS to present a plan and then demonstrate every dollar it spends is tied to implementation and sustainability around that plan. The other wrinkle that we have to deal with is the fact that the funds are received annually, and the state has until the end of the following federal fiscal year to expend those funds. So whatever is received in January of 2026, we're going to have to expend that, have it out in the field by October 31st of 2027. So you can't pool money and save it for later. This has to be a constant process of spending money to drive transformation. I referenced the objective criteria that are part of the workload funding award. 50 and the criteria is weighted, and it is data that is available to CMS, and they will make the calculations they purport in the fourth quarter of 2025. It'll be done one time, and this will be the amount that the state carries forward. At the University of North Carolina, their research team pulled the data they had available and charted what you see here on the screen, how the states would perform across these scores. This is not a guarantee. This is best data available at the time to UNC. Note, of course, that UNC is #1 in terms of the score, so that, of course, makes it suspect right there. But the good news is that Kansas is sitting there at #6. So that puts us in a good position going forward, is that half of our workload score should be favorable given how Kansas is measured across those rurality factors. What we're going to be concerned about is the 35% of the workload funds that are going to be awarded based on the initiatives that are presented in the state plan that address 10 factors that are detailed in the plan. Of course, you're saying, Marty, 50 plus 35 does not equal 100. There are also 15% of the score is based on state policy factors. So where does the state stand on a number of specific policy issues that have been identified? And those are separate and apart from the conversation here. What we're going to focus in is on the component of the workload funding that addresses the 10 factors that are specified in the NOFO. So this is where the NOFO is actually serving two purposes, and one we have to manage through in the next 27 days. The state plan has to hit on these 10 factors to maximize its score. So, and these are the only things that can be included in the plan. So if you develop a component of your plan, you're going to have to be able to tie it to one of these factors. And thus, what we implement going forward is the plan that reflects this work. So it's, yes, it's how we're scored and it's how much money we get, but then it's also the plan we live with for the next 5 years to implement that plan. And again, it is more prescriptive than we had anticipated. This is simply not a pile of money handed to the state where the state is then going to make grants to organizations that apply for money. That's not what this is. And this is not like the Provider Relief Fund during COVID, where we would present certain costs incurred to draw down dollars to help operations. In fact, there's very clear statements in the NOFO that, and also the FAQs that CMS has been publishing, that we're not funding ongoing operations. We are going to fund those activities that transform those operations. Again, recall that this money was created in part because of concerns of the impact of Medicaid cuts on rural hospitals. And that would lead one to conclude, well, wait, the money's going to be used then to offset that lost revenue. That is not the case. What Congress envisioned was, if the Medicaid cuts are going to hurt you because you're living in a fee-for-service world, we need you to transform the system so that you're more efficient, you're achieving better outcomes. And that's what this money is being made available to the states to accomplish.
Thanks, Marty. Just one pause. I know you have a lot to get through, but a clarifying question in the chat is, will the process determine how the state uses the full amount of funding, the base load and workload combined?
That's an excellent question. Yes, it is. It's two piles of money simply for how it's awarded to states. When that money shows up at the state, all of it has to be used to implement the state's plan. And that plan is built around these 10 factors. Great question. Okay. Let's get into the nitty-gritty, because this is going to impact the decisions you make. There are a dirty dozen, shall we call them, limits on the use of funds that are specified in the NOFO. So you can make the case all day long that we should be spending money on these things, but we can't. The federal government will not allow funds from this program to be spent on these issues. And of course, that starts with you have to be able to tie any expenditure of funds to implementing and sustaining the initiatives that you've detailed in the state's application. Each initiative must relate to at least one factor, but you could have initiatives that cross multiple factors. No construction or major renovation can be paid for with these funds, though CMS will permit minor modifications, but only if those modifications can be tied to enhancing a facility's functionality as it relates to a specific initiative. So take, for example, no value here, but if we would have dollars available to assist hospitals that are transitioning to the rural emergency hospital model, they could make renovations to their facility to enable them to operate under that model, as opposed to the traditional inpatient hospital model. That would be minor modifications clearly tied to a specific initiative. Number 3, no broadband infrastructure. 4, we cannot pay for food or meals in any context. No costs that are incurred pre-award can be used to cover. So you can't receive the money and then go back and pay for things done prior to the award. All of these are costs incurred or money to be expended after the dollars are received by the state. No lobbying activities can be funded by this award as well. The next set of these become a little more esoteric and applied. They're not as purely black and white as the others. But first is you cannot supplant an existing funding resource. So you can't take dollars away from a program and put the transformation funds in its place. Of course, creates issues where you've got existing programs that are funded by grants, and you anticipate that grant's going to run out in the future, and you want to be able to insert the transformation funds to follow that. That's questionable at this point, whether that would be permitted under this award. We'll hopefully get some clarification from CMS. Several folks have asked that question, but that's the type of issues we're dealing with here. You cannot pay expenses that are the legal responsibility of another state, federal, or tribal program. You cannot use the funds to backfill projects that have lost funding. So again, if you had a grant program that was discontinued, you want to redo that, start over again, that is not permitted. You cannot use funds for perpetual ongoing operating expenses with no path to sustainability. And I think that's said at least 5 different ways in the NOFO, but what they want only is transformational investments. You cannot replace, duplicate, or modify payments for clinical services presently reimbursable by insurance. So an idea of, well, we can transform if we pay more for docs to provide a certain service. We can't use the transformation funds to make that difference up between current payment and what you believe would be an appropriate payment. Any type of service you're delivering today that is reimbursable by insurance will have to be continued to be reimbursed by insurance. Again, there's some leeway here. What if it's a service that's reimbursable by one program, but not by another? Do we have an opportunity there to provide reimbursement so it's available to a more broad population? Another one of those questions we're waiting for CMS to provide an answer. You cannot fund clinician salaries or workforce development initiatives where the clinicians or the initiative beneficiaries would be subject to a non-compete agreement. And by a workforce development initiative, say that would be an example of a recruitment program. And if a doc was recruited to a community through that recruitment program, the employer for that doctor could not impose a non-compete on that doc going forward. And you cannot use funds to pay an individual salary exceeding $225,700. That's the federal limit. That applies both to individuals that are paid directly, the state, as well as awardees and subcontractors. You could pay a person more. It's just going to have to be that additional salary component will have to come from a source other than the Rural Health Transformation Funds. So those are our parameters we have to work around. We'll do our best to sort of referee our conversations around different expenditures to make sure anything we discuss is going to be squarely within the permission of the NOFO. And as I said, it's clear there's still some gray area here. But for now, I think we side with those projects that clearly fall within permissible use of funds, not finding ourselves in a position of CMS disallowing a part of the plan because it is not consistent with these requirements. There are then you cannot spend money on, but these are the you can only spend so much money on requirements. So there's of the total award that's received each year, a state cannot spend more than 20% on capital expenditures and infrastructure. And you see there on the screen the definition of capital expenditures that was included in the most recent FAQs. You have a 15% cap on provider payments to clinical services. And there are two types of payments here that are permissible, but are subject to that 15% cap. That would include payments for performance and alternative payment models that are tied to outcomes. So you're not paying for a specific clinical service, but you're paying a provider a reward for performing in a certain manner, achieving a certain score on a quality measure, coordinating care with certain types of providers, whatever it may be. Those performance incentives are permissible, but they're going to fall under that 15% cap. Also, payments that are made to providers for services that are not paid by insurance, but still are tied to a specific initiative, those are permissible, but again, are going to be subject to that 15% cap. What is not subject to the cap are payments that are made to providers that are not tied to the delivery of clinical services. Instead, technical assistance or assistance in building infrastructure, those are not going to be subject to the cap. There is a 10% cap on direct and indirect administrative costs. And again, that's going to apply both to the state as well as any subawardee or subcontractor. So the folks that are doing the work and making the transformation happen, they get 90% of the money. 10% of the money is to the project managers, to the data collection, to the report generation, to the contract monitoring, all of that work that moves the initiative forward. That cannot be more than 10%. The NOFO gives the states some leeway in defining what is an administrative cost versus an implementation cost or a programmatic cost. But again, we have to be attentive to that requirement. Finally, there's a 5% cap on funds used to replace a certified EMR system. That was very concerning when it first came out because one of the factors is data infrastructure and the need to be able to spend money on data infrastructure. Again, the FAQs published by CMS say, when we say EHR replacement, we mean EHR replacement. So any upgrades or enhancements or added modules to an existing system, that is not within the 5% cap. Okay, so those are our limitations that we're dealing with. So that's sort of our realm of the possible is within those parameters. There is interesting commentary in the NOFO and again in the FAQs about how CMS will evaluate initiatives and how you build an initiative. And the first comment they make, it is not about the quantity of initiatives you intend to pursue. It is about the quality of your initiatives. And that quality will be judged across 5 domains. What's the strategy that you're presenting? Is it a workable strategy? What's your work plan look like? And how are you going to monitor progress on the work plan towards implementation and sustainability? What are the outcomes that you believe you can achieve through your initiative? What's the projected impact on transforming rural health? And is it a model that is sustainable? So those will be the 5 criteria we have to evaluate any initiative by. The initiatives should be structured to achieve the plan objectives. So we're going to start what are the objectives we place at the top of our plan? What are we trying to accomplish with the plan? As we set those objectives, then that's going to drive what the initiatives are. And then the next question down, once you have objectives, I'll just pick an objective, for example. We want to lower, we want a statistically significant reduction in the rate of certain chronic conditions in Kansas. That means we've done a good job on preventative care. If we want that as our objective, what outcomes do we need to achieve to get there? That's how we start building these initiatives. And then what are the actual projects? What's the work we're going to do that actually get us to those desired outcomes? And for this, I want to reference for you what CMS has identified as the objectives for the program as a whole. And these 5 pillars, these 5 strategic objectives, both languages used in the NOFO, are make rural America healthy again. That's prevention and wellness, both primary prevention and secondary prevention. Sustainable access, so we're maintaining local access to care, as well as coordination for specialty care within the system to make those services available to rural residents. Workforce development, having a strong, sustainable workforce to provide care in rural communities. Innovative care, particularly focused away from fee-for-service reimbursement to value-based reimbursement, and also the delivery of care in more creative ways. And then finally, tech innovation. Very heavy emphasis on technology in this NOFO, and the identification of appropriate technologies, the implementation of those technologies, both to extend workforce, but also to go into patients' homes and help those patients with consumer-facing tech be able to manage their own health. So keep in mind, as we go through this process, those 5 objectives, because what we want to build are initiatives around those objectives that CMS has identified. And as we look at those objectives, let's think, what do we have? When do we know we've met the objective? So what are going to be our outcomes? And then what's going to drive us there? What are going to be the projects that are the component parts of this initiative, this broader initiative, those component parts that are going to deliver those outcomes that we're looking to see? Just by way of reference, when we have to develop an initiative, these are the key elements that are going to be required for the application. So if I'm thinking of filing an application in 27 days, and I know the application has to detail all this information about the initiatives, and assuming it takes some time to actually write the application, that gives us the time frame on which we need to collaborate among these initiatives that we're going to develop, providing that general description, identifying the appropriate metrics, and not only identifying the metric, but setting a target and telling CMS how we're going to collect the data for purposes of reporting on that metric. We have to provide a timeline for proposed activities. So it's a work plan, the detailed work plan of how we're going to get to our objective in 5 years. How much money it's going to cost. So each initiative has to carry its own separate budget, though predictably, we're going to have projects that cross initiatives. That one project will serve multiple initiatives, at least 1 or 2 or 3. We would figure out how to allocate those monies as part of the budget. And then, of course, the sustainability plan of what we intend to do once we achieve the outcomes and objectives. How do we maintain that going forward? So this is the work to be done in our period of time together, as again, we collaborate together to build these initiatives. So as we start working down this process, the place to always start is, what's the mission and vision of this rural health transformation plan that we are forming? So what is our true north? What's the vision of what rural Kansas, the delivery of healthcare in rural Kansas will look like when we're done in 5 years? I loved the question that someone posed. Are we going to be able to look back in 10 years and say, we spent that $1 billion as effectively as possible, or was it just merely a distraction going forward? So this is a draft. We'd love your reactions to this, but the vision is proposed, again, just this is for you to react to, is rural Kansas communities will thrive as residents lead healthier lives as they have ready access to coordinated and comprehensive healthcare services.
Thank you so much, Marty, and it's no shortage of things to keep track of, to keep us rolling.
Yep.
I'll help us facilitate through. So we invite you to share your thoughts on the proposed vision. Can you keep the vision up on the screen, please, for people to review? Thank you so much. All right. So as Marty said and read the vision, what's resonating with you and what might be missing? So we'll invite you to read the vision and take about 30 seconds to share in the chat or come off mute and share your thoughts to the vision. And we'll collect that feedback to potentially adjust the vision so that we are all having a shared vision to work toward as we complete the application. And the vision is consistent for transforming rural health in Kansas.
Carrie asked if the vision statement would be on the application itself. There's not a specific requirement that the plan state a vision, mission, and value statement. But certainly if you're going to develop a plan of this caliber and this breadth, our idea was that we want to make sure we have a very clear understanding of where we're headed. What's the big vision of what we're trying to accomplish? Again, so we can look back in 10 years saying, yeah, we hit the mark, we got there.
Jennifer.
I think there's a lot of great components to this statement, but one piece that feels a little missing is no recognition of the folks that are actually delivering the care. So we've got to have healthy people, but we've also got to have healthy systems.
Thank you, Jennifer.
This is Robert. I'd like to speak up actually for what Gregson and Henry just said, but I really do think that the key here, as he pointed out, is coordinated, comprehensive. I think that's come up a lot in previous conversations that we've had in this call, that I think all of us are wanting to broaden the healthcare spectrum and get better communication and collaboration across that spectrum. So I appreciate that part.
Thanks, Robert. In the chat, see synergies for coordinated access, coordinated comprehensive healthcare. A comment from Aaron, the focus seems to be on rural Kansas communities will thrive. Do we want to focus on Kansas patients and citizens? Okay. To move us along and to make sure we have enough time for our great discussions we have planned, I'm gonna move us to discussing the mission statement.
It looks like a lot of words. I'm the first to say that. But as you read through this, what you're going to see is this is just a regurgitation of the 5 strategic goals identified by CMS. If they tell you what they want, I always believe, tell them back that you're going to do it. And so that was the genesis behind this, is that this reflects the 5 strategic pillars that CMS has set forth for the program.
Thank you, Marty. Chad says, rather than healthier lives, maybe something along the lines of reach optimal health. David Jordan, in the vision, there might be a mention of sustainable comprehensive care. Yes, please continue to share chats on both statements. Ed says, great point, Aaron. There's a lot that needs to go into rural communities thriving beyond health transformation. Tightening this to patients or Kansans might be more realistic. Any thoughts that someone wants to share verbally about the mission statement? Anything resonating with you? Anything missing? And as you continue to think about this, we know that you can spend a whole day developing vision mission statements, but you'll have an opportunity to think it through and share with the team throughout the process. All right, we'll continue to share in the chat, but moving on to values.
These are sort of atypical looking values, if you've been through these types of processes before, but our intention with these draft values is to provide guardrails. As we talk about initiatives, and we're going to make hard choices, and there's always that risk of winners and losers when you make these choices. So our concept here is to provide guardrails. So as we make these decisions and have these discussions, what's our true north? What are we going to go back to and say, well, is it consistent with that value that we all identified? And here there are 4 for your consideration, starting with this idea of we have to transition from a sick care system, one that allows people to live their healthiest lives or optimal health, as Chad said. This idea that all rural Kansas should have access to a well-coordinated continuum of care, meaning local primary and social services, as well as seamless transitions to regional specialty care. And again, across all types of services. Rural providers should leverage technology to bridge geographic gaps, enhance care delivery, and empower patients. Again, I cannot overemphasize the importance that this NOFO places on technological advancements. And it's the running joke we've had on the application development team is the old Henry Ford quote: "If I'd asked the people what they wanted, they would have said faster horses." So it is going to take some vision by this team as leaders to identify where those opportunities are for technology to transform healthcare. And then finally, a bold statement that the fund should be exclusively used for the benefit of rural communities and no funds should be expended to support urban providers' operations. So again, look at these, consider them, what's missing, what's not accurate. Because again, the idea here is to build guardrails for our conversation as well as plan development.
Thanks, Marty.
Marty,
And
I just had a couple of comments, maybe related, or is this the time you want comments?
yes, please.
On number 3, it just may be wordsmithing, but it seems like we're telling rural providers rather than it being part of us, like rural providers should leverage. Almost sounds like an outsider indicating to rural communities what they should be doing. And so that may not be well received by, individuals in rural communities. I would largely agree with number 4, with the exception of, we are an ecosystem and we're all related to each other. And while the funds are utilized for rural communities, and I think that should largely be the focus, I think it would be a misstep not to recognize that rural residents do receive care in other parts of the state as well. And not that needs to be a focal point, but I do think that just needs to be recognized as well, that, our urban counterparts do play a role in ensuring quality, accessible healthcare in rural areas as well. But again, that should from my perspective, be just recognized.
This is Linda Mowbray with Kansas Healthcare. Chiming in on number 4, I totally agree that, we're not looking at the urban areas, but I'd caution that we not exclude them. Some of my providers in the urban areas have innovative ideas of how they've incorporated healthcare into HUD settings. So I think we need to be able to tap on those urban providers for their initiative and ideas and see which ones might be expandable out into our rural and frontier communities.
All right, I'm sorry to dominate at least another comment, but I think Dr. Aaron Fast raised a question earlier, and maybe you could just elaborate. There's so many definitions of rural. Is there anything that was in the NOFO that basically just defined, did I miss that, what rural actually is?
They use the non-MSA definition.
Okay, thank you.
That isn't to say that's exclusive. They're giving some leeway on that. And that they are very clear, you're not prohibited from funding any type of organization. It's not, these dollars don't have to exclusively go to rural hospitals. They said that's open-ended in the application.
Marty, this is Ed O'Malley. I don't know how to account for what I'm thinking right now, but I know we need these values to work with the feds. I get that. And I also know that this whole question about can you have transformation if you don't have stability is on the minds of a whole lot of people across Kansas, especially everybody, but especially our hospital friends. And I'm just wondering if there's a way, because these will be seen not only by the people reviewing the application, but they'll be seen by other people in Kansas. And they'll send signals to people in Kansas about what this group and what the governor is prioritizing. And I don't know how to do it, but I just wonder if there's some way that we can convey that we're about transformation and we understand we have to do that transformation in a way that helps these systems and these organizations be healthy so they're able to transform. I don't know how to do it, but that's on my mind. I'm worried about somebody seeing this and feeling like that question of stability and transformation might be lost.
And I think the closest CMS has come to addressing that is their discussion of major versus minor modifications for buildings. I know that sounds strange, but what they're talking about is, yes, we're not going to pay for construction. We're not going to pay for major renovations, but we understand that there'll be minor modifications, but to do that, you have to tie it to one of your initiatives. So that has to be a transformational purpose. Yeah. So if we could talk about stability in terms of it being part of transformation. So we want to, if the stabilization is done in a manner that it's not just resetting that facility to continue providing fee-for-service reimbursed services, but instead they're going to do something new, then I think that's going to be the basis for providing that kind of funding as part of an initiative.
Okay, I'm seeing a lot of similarities with comments around how urban providers also provide support to rural communities, rural community members. There are some suggestions for adjusting some words. I think we have time for one or two more comments and then we'll move along. Tara?
Yeah, I have a question and a comment. One, it was my understanding that some of the funding should be utilized in terms of sustainability to increase workforce. I think in Kansas, we know that that's, a serious concern that in the future, we don't have enough providers or healthcare systems to take care of our rural communities. And it doesn't seem like in the few things that we've shared, we've really addressed workforce as a focus of our application. And the comment I had is in terms of sustainability, I know we've had lots of conversation around rural and urban providers also doing rural, but for a program to be successfully sustainable, wouldn't we want it to be something that we could eventually roll out across the state for all communities? Just a question.
Thank you for raising that, Tara. I think that's a good segue into our next discussion. I thank you so much for your feedback. You can continue to provide feedback on the mission, vision, and values that were presented in the chat. And also, I know the team would be open to hearing additional feedback on those. I think it will be really important as they, can serve as the purpose and the true north, as Marty said, for the application. I think we do have a little bit of time to go over just some draft objectives and to provide some examples, and then we'll get into providing feedback on the application.
So, as your the mission statement, mission statement. I always get them confused. I apologize. If you remember, that mission statement was built around those strategic pillars identified by CMS. The objectives then, again, if we play this out logically, hopefully it's logically, that you identify objectives based on those strategic priorities. The objectives then will drive the initiatives, right? Because the objectives are what we want to achieve. So we will build our initiatives to achieve what we state as our objectives. So what you have here on the screen, again, draft form, but our attempts to take those strategic priorities the kind of the pie in the sky, and put them into measurable objectives. We're going to do X. And so take a look at these. Remember the first objection, make rural America healthy again. How do we translate that into an objective? And the draft here says achieve meaningful reductions in chronic disease rates in rural Kansas and avoidable hospitalizations for complications related to chronic disease. So again, focusing in on, we want the purpose of prevention activities is to prevent higher rates of chronic disease. So can we measure the effectiveness of our prevention activities that make America healthy again by looking at the rates of chronic disease? So that's what we're trying to achieve with the objectives. Take that concept of a priority and put it into a measurable objective from which then we can build around that initiatives. Again, we're going deep into the plan at this point, but to get a feel how these feel to you, what your reaction to, specifically what's missing or what's being overemphasized is that critical feedback for us. And again, you're not limited to, please don't limit your conversation to today, next Thursday, and the following Monday. You know where we are. Any person on the application team is very excited to hear any of the feedback you have. So please, it's an open door.
Yes, and we will make the slides available following the meeting so you can review and reflect between now and our next meeting as well. That's helpful to folks. Some comments include number 2, why doesn't include all rural providers with negative operating margins? Number 2, may need to be more inclusive, rural Kansas health systems. Some additional comment on number 2, a comment on number 3, HSPSA has so many factors, some we can't control. Number 1, does chronic disease include behavioral health? Number 1, could we focus more on ensuring rural patients have a primary care medical home to ensure access to preventive health care? Then it's not just chronic disease, but whole health, whole person. Right.
And again, as you're thinking of these, I want to emphasize again, it's a measure, right? There has to be something that we could say, we did this, we achieved this, we can measure that we did this, and thus we achieved that strategic priority. So that's my only caveat here, is we keep those as measurable, and measurable means we have the data, or we can get the data to in fact evaluate progress. So this is taking the next step. So if we have an objective, remember we talked about, we go from priority to objectives. We then asked ourselves, how will we know if we achieved the objective? What are the outcomes that we need to get to that objective? And this is, again, by way of example only, but this goes to that first objective about reducing chronic disease as well as avoidable hospitalization, so primary and secondary prevention. And these are just examples of where we know we have data that we can utilize. And I think you'll start to appreciate as we get to these outcomes, they start informing where we go with the projects that become part of that overall initiative. So again, reaction here, both to that process of how we build this out, but also the more specific, are we hitting the focus correctly? And I will often use the term, what are the drivers that will get to the outcomes? And those drivers then again become those component parts of that whole coordinated initiative around those objectives, around each of the objectives.
Carrie, please share.
Hi, can you hear me okay?
Yes.
I was having a mic issue and I interrupted you earlier, Marty, and said test at one point. So I apologize for that. So are these example outcomes you have, these outcomes, which would be related then to initiatives that are part of the plan? Are some of these specifically called out in the NOFO? I'm thinking about like the presidential fitness test, for example, that you called out. Are you attempting, or some of these attempting to reflect what the CMS is looking for, as well as being those drivers?
Yep. KRHIA would not have independently come up with the presidential fitness test, but that is one of the state policy factors that's called out, is the state requiring schools to move forward with the reintroduction of the presidential fitness test. And so again, if they tell you something, tell it to them back, is the theory of grant writing. And so that was the reason that particular one was highlighted.
Thank you so much. And we're seeing some additional comments and feedback in the chat. And again, there's a question from Denise. Are we going to be able to see reductions in rates of newly diagnosed cases of realistic in 5 years? And for some, you may see increases in diagnosis due to better screening and assessment and diagnosis. So she's thinking about the dementia may be particularly difficult. So a good consideration there. Yeah.
Denise, that is the bane of all work in healthcare. Is we can make the numbers look worse by doing a better job. But also just the time required to change behaviors. And I think that's something CMS fully appreciates, is how then we define our milestones. I mean, I don't think we're going to say we're going to cut the rate of heart disease in half in 5 years, but we want to make sure we're trending in the right directions. Even if it does mean we're just doing a better job of measuring it.
All right. Well, thank you so much, Marty. Not a small amount of information to get to. I do want to leave enough time for us to get into our breakout discussions. I'll now, if you have any additional questions about mission, vision, values, objectives, and outcomes, as you continue to review them following the meeting, and we'll have some time to go over it in our subsequent meetings as well. Continue to review and provide feedback to the team. I know they'll really appreciate it. All right. I will now turn it over to Dr. Bob Mosier, who will share more about the stakeholder engagement process thus far and some key questions and topics to consider as the application continues to develop. Welcome, Dr. Bob.
You, Sheena. Yeah, I think the first thing on my to-do list is get you an up-to-date photo. I think there's a little bit more gray in my hair since that last one. So appreciate everybody being on today and being engaged and great discussions, great conversations. And I know there still remains a ton of questions and particularly around the process of what's happening and what next. So what we wanted to do is kind of talk a little bit about what we've been doing since the announcement and the move into our first educational webinar back on the 25th already, I guess, whenever that was. But during that time, as we looked at the NOFO, there's an obvious requirement for robust stakeholder engagement. And how do you do that in such a short time frame and develop your transformation plan for the state and to have an impactful plan going forward? And so short time frame, and we ask for submission of ideas, initiatives. We ask for them to look at, what would be, at least 4 measures or milestones to monitor the success of that initiative, give us a rough draft on a budget and such. And we had a great response to that. We had over 177 submissions. And so staff and all, we've been going through those to look at the ideas, recommendations, and some are very detailed, looking at great innovations that are already being put into play and having success and how it might be ramped up to be spread across the state of Kansas. And so certainly interested in those, particularly those that address the 5 pillars or the 10 factors that Marty talked about. So there are some that are, just a little bit more superficial, but still, great contributions and ideas. And so what we've been doing is taking those and kind of aligning them around those 10 factors and the 5 strategic pillars, just to see, where everything kind of starts falling out, and then addressing all of those issues around what can be funded and what can't that Marty brought up, and start developing, groupings so that we could then reach out to leaders in organizations that are doing the work to look at, again, instead of multiple activities all doing something a little bit different, how might we combine to be a little bit more collaborative and integrative and have a broader impact across the state. So I'm going to share with you, these aren't all. We're not going to go through all 177 plus initiatives with you today, but just let you know we continue that work, and we continue to not only engage stakeholders that have been appointed to the Alliance by the governor's office, but also a number of other rural health stakeholders easily recognized across the state at various levels and experts. And we're having one-on-one discussions with them or their groups to gather a little bit more information and insight, helping to identify where there might be gaps or issues that we need to be thinking about as we are working with the state in developing a transformation plan. So, for example, you see here, emerging themes. So, under prevention, chronic disease, some of the YCMA programs and the virtual accessibility of some of the like diabetes prevention programs. A lot of food is medicine ideas and a lot already going on across the state. So, an opportunity to maybe convene the group to look at how to do this collaboratively and be more impactful. So you see the chronic prevention or chronic disease prevention, and so there's a number of other things on that some may fall out, as Marty mentioned earlier. There are a lot of technologies being applied, whether it's patient-facing, around activity to address osteoarthritis and to reduce hypertension, obesity, diabetes, all of that. And so there may be some of these that fall out under technology, but overall, we wanted to kind of group them into general themes. So you see quality as a driver of value-based care. As many of you know, CMS still is pushing that all Medicare recipients, beneficiaries will be in an ACO model by 2030. To me, this feels a little bit kind of like the back in the day when we decided we're all going to be computerizing our medical records and the challenges of everyone adapting to this new initiative. And so the same thing with value-based payment models. We kind of started, with the patient-centered medical home, a lot of activity to get to the recognition of being a certified medical home, but how does that apply, for participating in a value-based market? And we realize there is no cookie cutter approach to addressing and transforming rural healthcare. And we approach that with that idea. And we recognize resource limited environments, particularly in our more frontier locations, although some of our frontier centers and practices are quite innovative. And that's one of the benefits of rural health, is being able to move and adapt, implement perhaps a little bit quicker than a larger system. But one of the value-based care models is really identifying a way that we can help bring everyone up to be better prepared to participate in value-based payment models and then be attractive partners for ACOs and our clinically integrated networks, and actually also bringing in more fund flow into the practice and such. Workforce was brought up earlier, and believe me, there was a ton of suggestions around workforce, and you could start from junior high and high school around identifying health as a career choice and a variety of different programs, from allied health to becoming a physician, but all the way into supporting the students through college and applying into their respective professional programs, nurturing them to get plenty of rural exposure and experience, and incentivizing and encouraging them to practice rural. So a lot of those workforce initiatives have been kind of lumped into one, not to make anyone less noticeable, but to really identify how can we together through all of those make it a little bit more. And you'll see here later, we'll be having breakout conversations around about 4 of these particular areas where we'd like to have a little bit more discussion around the theme and the approach and maybe what we need to be thinking about around the planning and implementation. Next slide. EMS, I can tell you with last 11 years of traveling all around Kansas, working with rural hospital systems and providers, that transportation is huge. not only for healthcare, moving patients from one small hospital into a larger health system, but also with behavioral health. And so EMS, workforce was another one. And so we've got a major grouping around EMS and medical transport, behavioral health transport. And then behavioral health, another very common, finding and need and a gap in many of the community health assessments being done. And so how can we improve that and transform that to really benefit rural Kansas, but likely would benefit Kansas as a whole? And you see those items listed under that. And then rural partnerships. This theme is kind of, the transformation push that you see within the NOFO, but it's really, I think, also recognizing that if your regional medical centers are struggling to recruit specialists or adequate capacity or adequate nursing workforce to support the number of beds, that trickles down and impacts our quality of care and care of our rural patients as well. So it's really critical to have good regional health systems and important to have coordination, communication, and such with that. So you see a lot of the other partnership ideas that have come out of the request for information that we've been going through. So there's a lot of information, but right now those are probably the major themes that we've really seen. You see on the next slide, it kind of comes up around the data. It would be nice, that's one of the challenges around patient-centered medical home, having a focus around population health, but also getting out of the mindset that we've got a panel of patients and instead we've got a community of citizens that we need to serve. And so with the care that we're giving, can we get access to all claims database to be able to actually, look at not only what are the conditions and issues that are prevalent in a particular setting, but what might be a hot spot that needs to be something to develop a program around addressing that particular issue or problem. So we've got, KFMC that's put together a proposal around all payer claims database, WSU with their pop health and community engagement programming, and then Children's Mercy around diabetes and such. And they also have a lot around the asthma in childhood as well. Technology, a ton of suggestions with actual technology being utilized from Thrive, which is kind of a remote cognitive-based therapy for patients with depression and anxiety, where they may not be able to get in very easily without a great deal of challenge with transportation, distance, childcare, and all those other issues, and getting support that they may need beyond just medication. So mobile simulation training, AI, remote monitoring, remote patient monitoring, all of those are kind of looped underneath technology, but may also in some cases overlap with ACO preparedness and clinically integrated network development. And then finally, a grouping around dual eligible, which is called out in the NOFO. And there, is an opportunity with a couple of great programs in Kansas around, can we look at more rural expansion, taking a larger population, coordinated care management, some of the challenges of elder care in our communities, such as respite therapy and daycare provision. So lots of really great ideas, and boy, it sets the mind to racing and thinking about how to tie it all together. But we alone and the state agencies, really appreciate your engagement and willingness to help in looking at a few of these and giving us some feedback. And that's what we'll do with the breakouts. But we also have found with many of the smaller submissions and with some of the needs that we may need to look at and actually developing and a planning section, if you would, in that first year. We don't have to have everything just ready to go day one, but we may have several initiatives that actually need to have a planning phase and then, move on into the implementation. And in some cases, maybe it's creating a funding pool that would finance some of that work. And maybe it would be a funding pool that would support the adoption of some of the technologies. And again, rather than being the large state organization telling the rural practice exactly how to do something, having a funding pool where you can tap into that to get the technology, let's say, that you believe might best serve your particular system of care. So we'll be talking a little bit around funding pools as well in the breakout. Lots of suggestions for the utilization of community health workers within the care across communities and at different levels, different sectors. And so, looking at those and tying them into some of the initiatives that were submitted. The one thing that comes up again is workforce. How do we develop that? How do we make sure there's reimbursement to cover the cost of implementing that and at what level? And then primary care and public health integration, it really kind of comes back to looking at, the responsibility of doing population health within a community, and who are our partners and how well is that occurring, and particularly with now increasing requirements for screening for social determinants of health, and not just doing that, but acting on the positives. And that certainly, falls, further away from what we as health care practitioners are used to doing from a biomedical standpoint. But we, family physician, I will just say we are trained more in the biomedical psychosocial model. So, but we are trapped in the sense that we've got volumes of patients to see, time limitations, and maybe not at the level of expertise. So how do we do a better job on managing those patients? How do we recognize what are the poor health drivers in our community and work with public health, not only with surveillance, but education, programming, and whatnot? And so we'll be talking more about that model in the breakout as well. And then, the various things that we could look at that would help with the financial stability of our rural hospitals and rural health systems, as mentioned before, stabilizing, then transforming. And what would that, look like? Some of that may, have to start with, financial analysis and looking at, planning and implementation to increase revenue and decrease costs. So is there an opportunity to develop a bridging fund that would allow you time, to get these changes taking place before you have to, close the doors because you just can't afford to keep it open? So more to come. But you can imagine lots of really great conversations, and we look forward to continuing those with you today.
Thank you, Dr. Bob. We'll definitely get the picture updated for next time. All right. So we are going to, and thanks for providing that context for what's been coming up in your stakeholder conversations and submissions thus far. And so to help the application team and the state and this group move forward on some key questions that are coming up throughout the process, we've set up breakout rooms according to the topics that Dr. Bob just went over. So in a moment, we're going to have you self-select into the breakout room topic that you're interested in. It'll pop up. You'll go ahead and click on the box More, and then the breakout rooms will come up and you'll click the room that you'd like to join, and Lindsay is going to make those rooms available shortly. So when you are prompted, please select the room that you'd like to go into.
Forgive me if you already said this, Jody, and I missed it, but I remember you talking about the size of the pools. Do you have a gut feeling of what the average size of, a grant from these pools might be?
What we've seen in what was submitted by last Friday's deadline ranges a great deal in terms of size. It can be as significant as our rural health clinic would like to be able to provide a mobile clinic to reach out into the more underserved areas of our county. And that has a very different sort of a cost structure than something that might be a minor renovation in order to expand the capability to offer optometric screenings in a clinic, etc. So there's really not a amount that we were thinking about. We were thinking more around demonstrated need, innovation and transformation, and potential replicability, et cetera, rather than saying, as an individual organization, you can request up to $300,000 of this pool or $1 million of this pool. We were really thinking more around subset of leaders defining, as we look at this pool of folks who have submitted, which of these most directly apply to the intent of the Innovation and Transformation Fund, if that makes sense.
You betcha. Yeah, thanks.
We've had some submissions around the pool, the potential pools that also ask for waivers that we just don't have the ability to grant. We can't create a new type of provider under CMS or those sorts of things. So, some of what's been submitted are very, very worthy of consideration. They just don't fall within, our ability to be able to say, we would like to assist you in retrofitting your organization for this new type of provider when we don't have the waiver authority to say that new provider type is eligible. And we also have this challenge around billable services because there is a very specific cap on what we're able to do. And if we were to support billable services for every request that came in, we would blow that cap out of the water very, very quickly. So we're also trying to balance, as we think about these funding pools, how is this sustainable? It's an investment, and it's support, and almost in a way thinking of it as venture capital to help launch something, but is there a corresponding billable service that allows it to sustain? Because we don't necessarily have the ability to sustain that piece of the work, if that makes sense.
Chad had an interest, and I don't know if this is exactly what you meant, Chad, but I wanted to ask Jody about it, about regional partnership pools, so beyond one community. But I don't know if you meant this, or I was starting to think of this too. Would there be an opportunity to have a statewide pool, but is there any opportunity for regional pools? So you could have regional planning, but also regional distribution, or is that getting too far away from the grant money?
Actually, Carrie, you're asking a really great question that we're waiting for more guidance on. We see regional partnerships as an actual initiative, not necessarily a part of the pool, but really being able to incorporate in a statewide initiative the ability to support regional partnerships. And there's
Alrighty, so we'll go ahead and get started now. If anyone comes in after I've started my little instructional spiel, feel free to message me afterwards. So today we've heard Dr. Mosier describe key topics the application development team is working through and some questions they want you to weigh in on with your experience and your expertise. The topic for this breakout is community health workers, and we have 4 questions to consider. Before we dive in, does anyone have any questions?
How long are we in this breakout?
So we are in this breakout for 20 minutes, and then we will
Okay.
be transitioning back to the big group to share out thoughts. Thank you for that question, though. Excellent one. Alrighty. So today we're going to be working in Padlet. I'm not sure if folks are familiar with Padlet. I've put a link to the Padlet in the chat. So if everyone could click on that link to navigate to Padlet. So again, facilitating the discussion, we're going to use Padlet in addition to folks coming off of mute. So if you're not comfortable with Padlet, that's totally okay. We'll just have a group discussion. So today, these are the 4 questions that we'll be answering in regards to community health workers. We'll go ahead and give you guys some time to answer them in Padlet, but to do so, I want to give you guys a brief overview. So in order to add your comments, you'll click the plus sign above the question, and then you can write a few sentences into your card. And once you've added into your card, then it will appear below the question. To interact with other people's thoughts, you can add a comment or click the love button or like button, just using that feature there. We would love to know who is providing the comments. So once you're in the Padlet on the top right-hand corner, you'll see this icon here. And we would love for you to change your name from a funky little animal into your actual name. So I'll be renaming myself Shelby Rao, KHI, and then it will update. So before we get started, is everyone in Padlet? And are we good to go? Alrighty, well, we'll go ahead and get started. If you guys could take a few minutes, look through the questions, and then add your thoughts to each questions. I'll give you probably about 3 minutes now to do that. And if you can't get to the Padlet, feel free to come off mute and I can add thoughts to the questions for you. Alrighty, it looks like Jennifer has added to question 1. If anyone's having any issues, feel free to come off mute or chat me and let me know. And I can also add notes for you guys as well. Alrighty, well, let's go ahead and come back together as a group. Feel free to continue adding to the Padlet, but I would love to hear from you all as you're reading each other's different notes under the questions. What's resonating with you, or what questions do you have about some of the different comments?
I guess maybe for me, it would be helpful to have a little bit of a better idea as to what our ultimate goal here is in this conversation.
Okay. So can you speak a little bit more to that, like within this particular breakout room, or more so the conversation that we're having today as the Alliance?
Well, I mean, are we trying to answer the question, should community health workers be included in the Kansas plan, or are we trying to figure out how we're going to use them? Or I'm still just a little bit lost about why this is a specific topic that we're discussing.
So within, and I don't have specifics on the specific plans that were submitted, but as Dr. Bob mentioned, there was multiple different plans that included the integration of CHWs across the care system. So that was one of the key themes that was identified that they wanted us to talk a little bit more about and see what are potentially some of those areas that we could integrate CHWs across the different questions that we had today. Does that provide a little bit more context?
Sure.
Okay. And I can definitely take your question back after this as well, and have someone reach back out as well.
I think given that there's so much interest in this, like maybe maybe it lends itself to just some actual hands-on work, like with like work group or some meaningful contributions. I mean, I think it's great to get the feedback of folks in this room, and everyone here has good experience. And given that there's probably multiple proposals, like there's probably a way to build the strongest proposals in through like folks rolling up their sleeves and working together.
Gotcha. So more so maybe the ability to see some of those different plans and those strategies to see kind of what rises to the top. Is that what you're thinking?
Yeah, I mean, I think there's a lot of work that's happened before, after, and during this process that might be able to help the folks pulling the application better inform the folks pulling the application together.
Gotcha. That makes sense. Well, maybe what would be a good idea then, David? I know it's not like a specific thing on the Padlet, but maybe if you have ideas on kind of what work has happened up to this point that would help inform the process, maybe putting that in the plus sign on the update your name on Padlet column, and then that way we can kind of take some of those resources back to the group and maybe connect those a little bit as well as answering these questions. Alrighty. Well, let's go in question by question, just to see what folks shared and then see if folks could provide a little bit more context to their responses, as well as if anyone has any questions about responses, we can go ahead and work through those as well. So the first question that we have is, in what ways can community health workers be effectively connected to rural health initiatives that go beyond routine billable services? So Jennifer, it looks like you said CHWs can help improve outcomes and free up time of providers. Let's see. So does anyone have any thoughts about Jennifer's response to that question? Or for David's below, which is CHWs can help patients navigate an often fragmented and complicated rural health system. Beyond addressing SCOH or chronic conditions, CHWs can play a role in supporting elements of the pillars of the RHT program, including food as medicine, filling maternal care gaps, and supporting behavioral health and more. Any thoughts?
I mean, I would just say, painting with a broad brush here, I think clinicians do a great job of laying out what needs to happen. I think community health workers have proven a valuable tool in helping patients take those instructions and apply them to their daily lives. Like, how do I actually take an instruction from a physician that says, eat better and exercise more, for example? That sounds daunting for a lot of people, especially if you're an individual struggling with a lot of other social issues.
Mm-hmm.
So I think that person, a community health worker who walks with the patient and helps them navigate those obstacles and put into play the actual prescription, so to speak, that the physician or other care providers providing is proven helpful.
Gotcha. David, I saw you came off mute.
This didn't lend itself to any of the questions that you outlined, but I think there's a lot of opportunity to extend how and where CHWs function through this rural transformation grant, because some right now we're either limited to grant funding or to Medicaid reimbursement, which really just embeds CHWs in the healthcare system. So I think we could really pilot CHWs doing food as medicine, addressing social needs, managing chronic conditions, but they could be employed in nonprofit community settings, contracting with providers to supervise them. I mean, there's a lot of sustainability goals we could fulfill. So I just think there's some different opportunities to think creatively that extend not just the reach of the current capacity of the healthcare system, but even like the impact of CHWs beyond just placing them in, FQHCs and rural health clinics and rural hospitals.
Gotcha. Thank you so much. And Linda, I see that you don't have access to the Padlet. Let me try sending that link one more time. And then if not, then feel free to come off mute and share your thoughts, and I can take live notes for you. Alrighty. So there is the link again. So David, hearing a lot about sustainability and connecting CHWs to the work that they're really suited for, and maybe within some of these additional initiatives that could arise from the Rural Health Transformation Program, CHWs can be a connector of sorts. But just looking beyond the roles or the places that they're traditionally working right now. Alrighty. So I think that lends itself really well to question 2, which is what innovative or transformative roles could CHWs play in improving community health outcomes? So again, we heard a little bit from Brandon and David regarding food as medicine and other initiatives that were highlighted within the responses to the different initiatives or proposals that were put forth, as well as the notice of funding opportunity. But just thinking a little bit deeper on that, are there any other innovative or transformative roles that we can really see CHWs kind of living in and living within their communities in?
We might want to explore like dual purposed they may be a community health worker, but they also may be doing community paramedicine, or they may also be a pharmacist and a community health worker. You know, looking at that individual playing maybe multiple roles, knowing that some of our communities are small and won't have, it would just help keep that person busy and continue to provide services.
Gotcha. I've definitely heard of that within the maternal health space of doulas also getting their CHW certification and kind of vice versa, so that they can serve their communities in a variety of different ways. So thank you for bringing that up, Jennifer. I appreciate it. Any other thoughts regarding transformative roles or ways that CHWs can continue being innovative within their communities?
Maybe it's just thinking about alternate placements, as was brought up earlier. Local public health departments, libraries, food pantries, all of these entry points where individuals with social needs might be, surfacing in their community and having a place that having an individual that connect with patients in those settings and tethering them back to the healthcare delivery system or social support system could be helpful.
Yeah,
Gotcha.
I agree fully. I mean, I think the other piece, and this is like in the weeds, is we think about like there's a lot of case to be made on the sustainability policy pieces that would be a plus for this. But I think there's also like the alignment with other providers like parent peer support, which are really more on the behavioral health side. Like community health workers are doing much of the same thing, but the payment structure is much more favorable for parent peer support. So I think like if we can find alignment around this like peer workforce that really helps like provide lived experience, and it may not just be like because you experienced an SUD, but it's lived experience like in poverty in a lot of cases, not exclusively, that helps like people navigate the system and improve health.
Alrighty. Thank you so much for that, David. I appreciate it. Any other thoughts on question number 2? Alrighty. So let me just double check. I know we're running a little bit on time, so it looks like we have 4 minutes left. So let's go ahead and go over to question 3, which is how might CHWs contribute to programs that address social drivers of health, such as food as medicine or other community-based efforts? So I know there's quite a few folks in the room who have worked with community health workers quite a bit. So David, especially, I'm wondering if you know of maybe any existing programs in other states or other places where you've seen kind of CHWs contributing to those different social drivers of health programs that maybe would be good for the application team to consider moving forward.
Yeah, and I'm sorry if I'm talking too much. I mean,
No,
I
you're
think there's
good.
plenty of examples in Kansas and nationally where CHWs are screening for social determinants of health, and you're looking at outcomes based on like the Arizona self-sufficiency model. You're seeing like better indicators of improved self-reported health, self-reported mental health, less hospital stays, less ER visits. So I think there's like it's a pretty well established model in terms of CHWs and SDOH, whether or not it's an FQHC or a rural health clinic or even a hospital. So I think that that's pretty established. I think there's examples also within health departments, which I think Brandon brought up, which is like we need to make sure this is there. And there's also examples even in Kansas with nonprofits and like extension. I think what legs is reimbursement, which is the opportunity like to can you like find some funding until we can move this policy so that there's sustainability from a financing standpoint. I think there's opportunities that like other states have done really cool things with, CHWs in food as medicine and CHWs in maternity care. There's also a great example here in Wyandotte County where, on the public health side, CHWs in maternity care and home visits, which could be like extended to rural. Again, this is why there's, I think, opportunities here with sustainability and innovation and community-based employers, but the evidence is there from other states. Community paramedicine's another one. So Yeah.
Gotcha. Alrighty, well, it looks like we have our breakout rooms closing in about 55 seconds. So if anyone has any last thoughts on question 3 or question 4, feel free to come off mute or keep on typing. And I'm excited to hear from other groups as well on what ideas they were thinking about. So feel free to come off mute.
I think on question 4, it's just important as we're putting all this together. We see the potential to use community health workers in a lot of ways, but we're going to have to make sure we actually have a supply of community health workers. So we need training and we need people who are willing to do this. We need career promotion. I've had the privilege of seeing a lot of these workforce proposals, and let me tell you, there's a lot of need for these folks, but we need to build the pipeline for them too. So we just don't want to lose sight of that.
Yes. Perfect. Thank you so much, Jennifer. I appreciate it. Any last thoughts before we get kicked out? Alrighty.
Hello, everyone. Welcome to our breakout. We'll give folks a second to hop in. Feel free to turn on your camera if you're willing and would like to do that. There'll be opportunity for discussion as well as sharing in chat and on a tool we have. As a reminder, this is group 3, primary care and public health integration. So if you're not in the group you thought you wanted to be in, you can go back to the main room and come back. Okay, so people are probably still coming in here. I'm just going to drop some instructions here into our chat. So we are going to use a tool called Padlet. So those that are able to, you'll find a link in chat and I will share my screen. Okay. Can you all see the Padlet now? Great. So you should be able to access this Padlet using the link that I put in chat. I will put it in there another time in case anyone missed it. So as you're joining, a couple notes. If you could rename yourself, that would be really helpful for the discussion and for the breakout. You can rename yourself by coming up here to the top right. Mine shows a picture, but yours likely won't. You don't need to log in, but you can click on this circle and you'll see an option to change your name. So if you would like to do that, that would be great. How we're going to add comments. So we have a set of questions here around the topic of primary care and public health integration. To add a comment on any of these, you'll just click this plus button above it, and a pop-up here will show, and you can type your comment. Once people have started adding comments, you'll be able to add your thoughts onto their ideas, as well as add likes if you would like to do that. So I hope we're all here now. I will drop the instructions one last time. And before we dive into these questions, Dr. Mosier, is there anything else you would like to add as a setup for our topic and our discussion here?
No, just that, I think everybody comes into the discussion around the integration of public health primary care with a little different perspective. So, I think, again, we want to broaden it out to think of the community, the population as a whole, including those who aren't necessarily patients of the local healthcare practice or hospital. But yet live in our community. How do we, make sure that they're getting their needs addressed? And we think of public health as just the local health department, but that's really all of the other, community-based organizations and services that are available that we often need to think about. How do we plug patients into their systems of service?
Great. Thank you, Dr. Mosier. So we're going to begin by just giving you all a few minutes to look over these questions and start to think. And then when you feel ready, you can begin adding your thoughts and ideas under each of these. And as a reminder, you'll do that by clicking this plus button above the pinned question. There are 5 questions here, and our breakout is pretty quick. So we're just gonna remind everyone to be efficient with our time here. We will be called back around 3:50 here. So I'll stop, I'll pause, and give folks a chance to read these questions and begin adding your thoughts, and then I'll come back on and facilitate some discussion. I see some ideas starting to come in. If anyone has issue adding your thoughts, just let me know. You can also share them in chat or come off mute and we can add them that way. And I'll just flag also question 5 if you didn't scroll over, and question 3 here. Don't miss those as well. Got a lot of discussion, a lot of thoughts on question 1. Here soon, I'll invite people to come off mute and comment or add any additional thoughts on discussion. But just want to encourage folks to also look at some of our other questions. I know we have a short amount of time, but question 3 and 5 and 4 especially. Love to get some more thoughts on those questions.
Could you scroll back up on question 2? I can't see the full body of the question. Thank you.
And I'll just, now that we've got some thoughts on all of them, I'll just invite anyone that would like to come on and share some additional comments or ask a question on something that someone else has shared. Would love to have anyone share what's catching their attention or add any follow-up points. And if folks are still adding, that's okay as well. You're also able to comment on other people's ideas, so feel free to do that. You can just click add comment or add a heart, as someone did here on this idea. And if the person that is coming in is anonymous with a red icon, if you're able to rename yourself, that would be helpful. Or in chat, just let me know who you are. That would be helpful for us for any follow-up discussion.
Wyatt, this is Dr. Mosier again, just to kind of inform the group here as they are thinking and writing really great responses. You know, as you look through the NOFO and you listen to the federal folks talking about the Rural Health Transformation Program and the intent and what they hope to see, and they come up with words like right sizing, which sometimes means, different things to different people. It could mean consolidation, to have a more regional approach to services and whatnot. And some of the, organizations and activities that folks have mentioned, are I think some good examples of that, including, realignments. But just wanted you to know that right sizing, was mentioned often, and that could apply to public health. It could apply to the rural hospital, to consider maybe they don't need acute care services, that they should think about rural emergency hospitals as part of the viability and sustainability. So I just wanted to throw that.
Thanks, Dr. Mosier. Anyone else, feel free to come on and share some comments or discussion now that we've got quite a bit of ideas here in our document, and feel free to scroll around and check them out yourself. Any ideas, any comments?
I think Anonymous has been identified. I recognize Beth Aller.
I would say for me that I think it's important that we talk about the healthcare spectrum, and primary care and public health is important. But then we have to broaden it, because public health is so much. I mean, it's not just health, right? I mean, one of the things I teach my students is that's environment, that's clean water, that's safe living spaces. That's so when we think about these things, I mean, I think it is right, as in question 2, where it gets into the social drivers of health and some of these other ideas. And I think that's the key to prevention, is how do we expand health and even flip that, because our communities being economically successful is often tied to the health status of those who live there. I mean, Kansas Works has this great program, right, that has been focused on
those health issues that keep people from having jobs. So I just think when we talk about this more intentional collaboration, we have to move beyond the public health department and the primary care provider to think about all the other components of a community that need to be brought into that. And then also the second question, which is, but I can't ask a doctor to do that. So, right, just like with everything else, we have to create models where that's determined through the healthcare visit and other approaches, but where there's a methodology to then link people to those resources where you're not asking the doctor. And I saw someone, the idea of giving people something where they can use a URL or some other way to go find those resources. But I think we have to have, whether it's a care manager or anyone else, whatever we use, that linkage. First of all, those relationships have to happen between those community groups. But secondly, beyond those relationships, you have to provide that assistance to work through systems and understand systems to even get anything accomplished.
Thanks, Robert. Anyone want to add on to what Robert shared or share another thought? And Beth, we've got you noted as the anonymous person. So thanks for that. Anyone else want to jump in? Thank you, Robert.
I think just to piggyback on that, I was the one who commented on the QR codes or whatever at every visit we have for that. I think this is where it gets a little ticky-tacky, because if we don't have the resources to give them and we ask these questions, but then we have nothing to offer them, that gets very tricky, especially in a 15-minute checkup. So that's why we use the QR codes, because a lot of times it's like, I just don't know where I'm going to get my groceries next week. And if it's a simple question like that, I can say, okay, here's all the food pantries in town. This is where these are the numbers to call. This is where you're going to go for that. If it's different, like I got kicked out of my house yesterday and I don't have a place for my 4 children who are seeing you today for their checkups, then that's a different conversation, which takes more time and effort and resources as well. But you have to have those resources to offer someone before you even ask the questions. Otherwise, there's no point in asking those questions during the visit.
Thanks, Sandra. I think that's a great point. And the thing to think with your experiences, while those resources may not exist within the community and the provider doesn't necessarily have the time, to kind of, how might we accomplish a warm handoff, either in person or virtually, with the community-based organization? Maybe that's who employs a community health worker, or maybe it's the local health department who does that, but that we could hit the easy button. What do we need to put in place to make it that easy? That we know someone's going to follow up with them. They'll let us know what they did. They'll communicate back to us so we can put it in the record. So that's kind of one of the things, that as we've talked with some other states and we get the information out of the NOFO, it's what would really be transformative in that type of integration that's not happening today. What would we need? And I saw earlier, Mr. Bowman talking about, how limited the EHR capacity capabilities are in local health departments. Having a common platform of communicating about patient care, transparency, and communication are critical to develop that type of infrastructure. But yeah, with your guys' experience, just looking for any thoughts around what would need to be in place to make this really transformative and work better.
So just flag that we only have about 4 minutes left. So a couple of things. I saw a hand raised, so I want to come back to the raised hand. I think it was Tara. We likely won't have time to hear from everyone, so please come in and add comments if you have thoughts to add on to someone's point. Continue to add throughout the Padlet. You can easily add comments on individual ideas, just clicking right under where it says add comment. But let's go back to Tara, if you want to come off mute. Yeah, go for it.
I'll just type in my chat. I'll type it in the chat. It's a long one, so I don't want to use up our last 4 minutes here. Thank you, though.
Okay. Thank you. Kelly, did you come off mute earlier? I'll come back to you.
I did. Thank you. Yes, I just wanted to say I've had great experience with that integrated care in community health centers. So working with those CHWs, because most of the patients that we see have these social drivers of health that are really preventing them from achieving the goals, the objectives that we listed for chronic disease prevention. So I think, like Sandra mentioned, that none of us who see patients have more time to spend to address these. So we really do need those sustainable partnerships. And then Iris is, I couldn't think of the other apps that people use, but they're happening across the country where there is a database of community resources that you can put in a quick referral and say, my patient needs food, they need housing, and they need substance use disorder services. So I really think something like that could be useful too.
Thank you. So as you likely saw, we have a pop-up. We only have 50 seconds left. So last call for any final comments for the group. Otherwise, Dr. Bob, any final thoughts on some of the things you heard and the ideas you saw in the Padlet?
All great contributions. Really appreciate everybody's input, and look forward to digging into these in a little bit more details, and we may have some follow-up questions that we'll reach out to folks.
Great. Thank you all. We'll see you back in the main room.
All right. And then my second step is to welcome all of you and thank you for joining. My name is Cynthia Snyder, and we just heard from Dr. Mosier about some key topics for the application development team. And so what we've got, the team has some questions, and they want this group to think through them through. So the topic is financial sustainability. We have 4 questions to consider, and before we dive in, I'm going to ask Marty if, Marty, would you like to add some comments or kind of level set the group?
No.
No. Okay, we'll
highly
jump in.
qualified group. Go for it.
All right, so I'm going to drop into chat, and what you'll see there is a Padlet that you can open. So if you'll do that first action, it'll open you up inside the Padlet. And the Padlet basically is a facilitation tool that we're going to use to help folks as we go through the discussion. And let me share mine. You're certainly welcome to open and add. All right, so everybody should be able to see that. And basically what Padlet does, we've got our 4 questions along the top that we'll discuss today. Just an FYI, if you are not logged in as your in your account or didn't catch that little rename section, it's going to give you a funny animal name. So in order to change that to your actual name that you would prefer, just to go ahead and click on that icon in the corner. We've got 4 questions that we'll cover today, and pretty quickly because they'll jump us back into the main room at about 10 minutes till. So the first question is, what does financial sustainability look like for rural providers under the Rural Health Transformation Model? There's a plus button on top, and what you basically do is add your thought, publish, and then it will show up with your identifier. If you want to add a comment, all you do is add that underneath. So as folks kind of think, we'll take a few minutes for you to look at the questions and kind of think and orient to the task. But as you're thinking about each of these questions. You can go ahead and add your thought panels to each of the questions at any time, but we'll cover them and kind of reflect and talk, and then also give Marty a chance to, if she wants more information from us, or to kind of further elaborate, I'll ask folks to come off mute and tell us a little bit more. So go ahead, and I know we're short on time, so just take a minute, look at the questions, and start to think about your responses. If you have any questions on how to use the tool, it truly is as easy as basically add a sticky note with the plus, or respond to someone else's comment.
Yeah, just as you guys are thinking about this first one, I mean, one challenge we face is that data on the financial condition of hospitals is readily available, and that's going to include their rural health clinics as well. But for other provider types, whether that's nursing facilities or CBHCs or FQHCs, it's the challenge of getting that data available so that you can measure improvement. So if there's sources of which we're unaware, please share.
I'm not sure what makes the hospital financials transparent. For nursing homes in particular, we have Medicaid cost reporting, which is extremely detailed on both our financials, where that money goes, but even it goes so far as requiring balance sheets and all kinds of things for nursing home.
Is there a data source of publicly available cost reports? That's what we use for hospitals, is the publicly available databases.
I don't know. I know that the cost reporting is available through KDAD.
Okay, and Rachel, I went ahead and took the liberty to go ahead and add a tile for you. And then with that information of the cost reporting, and then it looks like Aaron's our first tile. Transformation funding for 5 years is great, but although I live in an ACO world, in my practice in primary care, still live in a fee-for-service world in specialty and hospital care. And so, Aaron, actually, I'm going to pull you across, and I'm going to add you to question. Whoops. I thought that was going to be easier. It's really kind of a question. It makes sense also too in question 3, where you talk about the barriers to participating in the value-based arrangements with payers, and it's that transition piece.
Well, I would say, I mean, again, speaking from a hospital standpoint, but also, financial sustainability looks to me as though services remain open in our rural communities, and our rural residents continue to have access to the healthcare services they need. And that includes all of our hospitals staying open in those rural communities. Every community has access to primary care. So to me, that is what I think of when I talk about financial sustainability, is that services remain in those communities.
Okay, and Shannon, I went ahead and made you a tile too, and kind of hopefully captured. If I didn't capture a point that you're making, please just add that into the comment there.
Maybe I'm doing it wrong. I thought I added a comment, but
there's a little pink arrow that it's the publish, and so you'll hit a plus here, and then after you write something here, then the pink dial will say publish, and then that should pop it up on the board.
Okay.
And 2, if you made a comment under somebody else, that shows up a little differently. So it looks like right here that you did.
Yeah, I commented under somebody.
Yeah, which is fine. Absolutely fine. All right. Looks like we've got another comment from Kiana, or a comment from Kiana on the public-private philanthropic partnership as an ecosystem of providers who have facility with and/or proficiency in performing in value-based care models, buttressed by solid data infrastructure, and data and that technology piece for creating that data. Certainly a part of that. Oh, thank you. And I'll go ahead and move us to the second one. How should Kansas approach the transition towards value-based reimbursement in rural settings? And Aaron, I think your comment actually goes here as well, that it's fee-for-service ward for especially in hospital wards, and how do you transition to that?
Yeah, and my comment just really is around, value-based reimbursement models take volumes. And so clinical integration is definitely needed if you're talking about a high value network to make it work. So that's kind of what my comment is around.
Thank you.
So this is Jeremy Presley. I'm not able to type because I'm driving right now, so I apologize.
I'll type.
So, but I think education is really where we've got to start with that. I think there's still a lot of people who don't really understand the concept of value-based care and how those models really work, why they're the direction that everything's pushing towards, and what the onus is behind that. I'm always surprised that as many years as ACOs have been out and been going, that it's still not as widely understood. And I think that's where a lot of, especially in our rural environments, I think that's where a lot of the discomfort and angst comes, whether from a clinical private side, hospital side, how to meld in the care facility, long-term care facilities as well. And so I think a lot of it comes with starting with education.
All right. Thank you, Jeremy. Gosh, this time is going really, really, really quickly. Feel free to add tiles into any of the questions, and then we'll kind of keep going and making sure. And Marty, as you have additional questions within the section, or want somebody to say a little bit more about the idea that they're bringing forth, just let us know.
Well, this is one thing too that I think goes back to the rural health transformation. That comment about none of the money go into urban areas, because there needs to be an infrastructure to make a value-based program type work, and utilizing what already works well in larger, maybe urban areas may also save some money, but give us the education, like was just mentioned with Jeremy, that may be needed in our rural areas to make this work. They already have the ACO set up. They have already learned the lessons around value-based networks. So could be a good resource to tap into.
All right, thank you, Shannon. Let's go ahead and jump to question 3. What are the barriers to rural providers participating in value-based care arrangements with payers? And I think, Aaron, you've touched on this.
Yeah, I'll make a farther comment. This is Aaron Fast again. Medicare with CMMI has robust value-based options for different practices and ACOs to choose. And, from our perspective, what we've seen, Medicaid and commercial payers are not interested in having a robust system like that. And so to the extent that we can, encourage or leverage state opportunities to have a robust system comparable to Medicare, and then we're not, trying to meet metrics for multiple different systems. Simplicity is really important. And, a lot of the patients in rural areas have Medicaid or Medicare, but not all of them. And so we need to include the commercial payers in this as well.
All right, thank you. And then Aaron Dunkel has added that the volumes can be an inhibiting factor with most. And then Rachel has added that as opposed to larger corporate long-term services support, the rural long-term care providers tend to be more standalone. And that's another challenge in terms of a risk-based. All right.
Can you all hear me?
Yes.
Kiana Thomason with Health Forward Foundation. I would want to punctuate what Jeremy mentioned around kind of system and provider education and the partnerships that are necessary that Shannon spoke to. I think being a part of clinically integrated networks and having relationships with different urban systems for different things. Like we might have one relationships for ortho, hips, and knees, another one for heart, all these other types of things to help you help rural practitioners or systems be able to perform optimally, as well as how to share data infrastructure, so administrative integration as well, where possible, realizing that so much of the payment systems are population based, and there's already a dearth of data infrastructure, and how might rural providers work with the data channels to be able to get the insights that they need. Even urban centers struggle with this as well, so there's no panacea anywhere. Definitely not suggesting that, but I know it's more challenging in terms of the cost of those programs, infrastructure rather, in rural. I also think that working with health plans really closely it really matters in terms of how to get their unique partnership and support on medical homes and quality programs in rural communities, because most health plans want to have a one-size-fits-all approach and hold rural communities to the same standards as urban centers, and that is not viable.
Thank you. I think we've just got about 1 minute left. And taking from the challenges and the barriers in question 3 and Kiana's comments is what resources do rural providers need to overcome these barriers? Erin's discussing transitioning to a rural emergency hospital, so great work on that. Education and specialized support safety nets for rural long-term care providers to remain open and main service in increasingly aging rural populations. So feel free to add cards to any of those. And then Marty, do you have any questions for our final minute?
Good.
Well,
This
my
is very
comment,
helpful.
yeah, Cynthia, I mean, and I'll type that in, is again, you talk about the resources and the financial resources to do that, to have things like nurse navigators, people that are really navigating the chronic care of this population, from the preventative to the follow-up to the, again, and that goes back to infrastructure as well, which includes dollars, but the resources as well. I mean, where do you go when somebody in Elkhart, Kansas is struggling with transportation to get to their doctor's appointments? So again, it goes back to what we've already talked about before, is it that whole infrastructure and the whole collaborative of population health. You got to have those resources to make an ACO work, because your whole idea of an ACO is to reduce all of those chronic cares patients and making them healthier. And you've got to have those resources to make that change.
Right. So that community engagement piece in terms of all the components that contribute to a person's health. So thank you, Shannon. Do you want to make the card, or you want me to make a card?
I can do it real quick.
Perfect. All right. Lindsay has been graceful and given us an extra 2 minutes. So again, feel free to add to any of the cards. And then let's see here. Education and sort of those specialized supports have come up in a lot of themes, whether it's understanding what the systems are, understanding the values of certain kinds of systems, understanding what through community engagement, what services are available for that whole person care. So I think education has certainly been a theme within this. Erin, interested in hearing more about your rural emergency hospital experience. So you've already done some of the hard work in terms of the transitioning. What's your transitioning advice for the group?
Well, just like if you want transition, one dish, everyone to eat,
Right.
and you know, there's about our situation, with the group, but I think we can
Oh, Aaron, I'm having an
see
awful hard time with your audio. Do you have a headset or anything handy, or maybe point more towards the microphone? Oh, sorry. Now I've lost you. Oops. Okay. Well,
I don't know if this.
now, sorry, Aaron. Now we're at time, and they're going to have us pull back into the main group. So we've got about 45 seconds for anybody's closing thoughts.
I was just wondering, Marty, do you have any last minute thoughts?
Well, yeah, one thing that's just been in my head today, because Secretary Stanek shared a report, was a survey of Medicaid MCOs, and one of the sections in that survey that they do annually is on the transition alternative payment models. And they were asked to identify what have been the obstacles. And of course, it's like provider readiness. It's all the provider's fault that we haven't made transitions to alternative.
All right, we're going to do a quick share out and then offer some time for closing and next steps. I'm going to turn it over to my colleague facilitators to share out key items that came out during the breakout sessions. I'll turn it over to Shelby to share about the community health worker group.
Hello, thank you, Sheena. So we had some really great conversations within the community health worker group. We really talked about community health worker sustainability, and that was kind of a central theme throughout our conversations. So thinking about things like how can we establish pipelines or pathways for community health workers to get trained, as well as working within their communities. We also looked at what are some of the different access points, what are some innovative access points that community health workers can work in order to reach out to their communities in more untraditional ways to get at some of those social drivers of health. So looking at things like local health departments, libraries, food pantries, and other community hub access points. So those were just a few of the things that we talked about today, but I'm excited to learn more and continue the conversation around community health workers.
Thank you, Shelby. And that group's charge was to discuss how community health workers can can support initiatives in the application. So what ways can they be more effectively connected to rural health initiatives that go beyond routine billable services? What innovative or transformative roles could they play in improving community health outcomes? How might CHWs contribute to programs that address social drivers of health, as Shelby mentioned, and what supports would help maximize their impact in rural settings? So thank you so much to the group who discussed and provided those ideas. I'll now turn it over to Wyatt to discuss key themes that came out of the primary care and public health integration discussion.
Thank you, Sheena. Our group had a great discussion as well. We were digging into 5 different questions, all centered around primary care and public health integration. And a few things that stand out. There are lots of examples of successful models, successful collaborations and partnerships going on in the state that many people pointed to, as well as really productive community partnerships that they have that can be leveraged for this sort of integration. There was an acknowledgement of the challenges that a lot of healthcare providers and healthcare entities may have in trying to serve all the needs that are identified, especially through social determinants of health screening, and the importance of having those partnerships with public health as well as other entities in the community. Challenges around data came up, and data interoperability and data sharing. But overall, the main theme was a recognition of the value of this integration, as well as some of the challenges, but a desire to look to the examples that we already have in our state where there are successes.
Thanks so much, Wyatt. I'll now turn it over to Cynthia, who discussed financial sustainability with the group. So I'll turn it over to you.
Great. So thank you to the group. And our first charge was, what does that look like? And really sustainability boiled down to services remaining in communities. I think that was a very common theme. And as the approach of transition, again, education came up as a theme, both in this section and as in the resource section, is just an opportunity of understanding what's the value of value-based care and how the community is engaged and how it serves that whole ecosystem. For barriers, there were a number of barriers in terms of below volume, adequate payment for supportive services, standalone providers, and their ability to differ risk-based arrangements. And then, as we solve some of those challenges, what resources are needed, and education certainly was the most common theme within that.
Thank you so much. And I will share about the discussion that we had around funding pools. So we explored if Kansas were to establish funding pools like a community investment pool, a transformation pool, or innovation funds, what principles should guide their design, what criteria should be in place, and what kinds of projects or partnerships would benefit from a model, in addition to how the funds could be used to strengthen collaboration. So, sustainability was a key theme that brought up. So, the funds, if they were established, they should be sustainable beyond 5 years. They should be easy to apply to and have minimal red tape in order to maximize impact. And they should be able to be replicated in other communities. Um, there should be a multidisciplinary stakeholder group to perhaps review requests for funds. And there should be expecting to have realistic outcomes for the time period of the funding that would be available in the pools. The application should require or incentivize collaboration between sectors. And having the ability to maybe have a regional focus or opportunities for regional funding pools to be discussed, in addition to um, finding a way to share stories or to help people understand how these pools are being used to improve rural health in Kansas. And I know that was a very quick share out, but being respectful of time, we'll go ahead and turn it over to next steps in closing. I'll turn it over to Jody Schmidt.
So much. So as both Marty and Dr. Mosier highlighted, we are working now as we have reviewed each of the 177 plus submissions that have been received to really identify those areas of commonality and where can we bring organizations with like purposes, like outcomes, like implementation plans together so that we can move from individual submissions to a true comprehensive state plan. At the same time, being mindful that we want to reduce duplication and be cost effective and be able to really understand how we can maximize these funds for statewide transformation and stay within the requirements that Marty reviewed in terms of caps, in terms of the limitations and the exclusions that are part of the notice of funding award. So that means we are following up with a number of folks on this call and organizations that made submissions to have those conversations around. We have 4 of you have an interest in food as medicine, for example. How might we take the strongest elements of those 4 proposals and bring them together into a truly comprehensive approach? And then how might we layer in some recommendations around community health worker utilization into that effort? Again, to broaden and strengthen its opportunity. As we look at the PACE opportunities, how might we bring those together to support not just the regions that were included in the applications, but what resources would be necessary to expand that more broadly into some underserved areas of the state? How might we coordinate between the multiple agencies that have some very clear visions on how we address the EMS issues. So that is really the next step in the work that we are doing, is to work with those who have some very innovative and transformative ideas and bring them together into a plan. And the goal of being able to share with you at least a preliminary framework for how we would propose to do that and translate it into those core initiatives that Marty described when we get together again on October 16th. And then be able to have you, to provide you the time to digest that and really come together on the 20th in order to translate that into the best possible plan that we can under such a short timeline. So that is the framework for how we are intending to move forward. We are certainly open to your thoughts and recommendations as we work our way through this process. Any questions for me or Marty or Dr. Mosier as we think about the framework? I would add the caveat, oh, by the way, I'm also working on the budget to make sure that we can achieve all of these things within the dollar limit that's been identified. Well, Sheena, if there are no questions, I'll turn it back to you.
Thank you so much, Jody. And once again, thank you for participating today. We know there are many unknowns still, but thanks for providing the feedback, and hopefully this meeting was helpful and beneficial, and we will look forward to seeing you at our next meeting on October 16th from 2 to 4 p.m. Please look out for meeting details and information ahead of the meeting, and for future information for the in-person discussion we'll have at KHI's building in Topeka on October 20th. Thanks again, and have a great afternoon.